The first basic that I would like to share with you, the anatomy of the orbit. We all know that basically the orbit is a pyramidal shaped structure where the anterior part it is widened and the posteriorly it is narrow, and it contains a very important structure, the globe, the extraocular muscle, the nerve and the fan. We should know the volume. The normal volume is 30 cubic centimeter because this volume helps us to make an adjustment when we do a fracture repair or when we do go for reconstruction. It is composed of 7 major bones which forms the 4 walls of the orbit, and these 4 walls are the roof, the floor, the medial and the lateral wall. So let us go to the wall by each. So the roof of the orbit is basically formed by 2 bones, that is the orbital plate of the frontal bone and the lesser wing of the sphenoid. But if you look here very carefully, you have the very important structure. This is the lacrimal fossa, this is the trochlear fossa, and another important structure is the superior orbital fossa. So if we go to the lateral wall is very interesting because it's the thickest and the strongest, and this is basically composed of the orbital plate of the zygomatic bone and the greater wing of the sphenoid. Next, the medial wall is very important for us because most of the fracture occurs in the medial wall, and it is the thinnest wall having formed by the frontal process of the maxilla, the lacrimal bone, the orbital plate of the ethmoid, and also the lesser wing of the sphenoid. And if you look very carefully, we have the 2 most important structure. One is the optic canal and one is the superior orbital fissure. So this superior orbital fissure, it forms the medial end of the lateral wall and the lateral end of the medial wall. So this is a very important structure we should know because most of the important structures pass through the superior orbital fissure and also the optic canal. The floor is also important because we have the 2 important structure formed basically by the maxilla and also the palatine and the zygomatic bone. And here the important structures are basically the infraorbital groove, through which passes the infraorbital nerves and the blood vessels, and the infraorbital foramina, which comes from the orbit to the maxillary region. So when we talk about the fractures, now we know the anatomy, but what are the other important structures we should know about the face when we think of the fracture reconstruction? We should know about the craniomaxillary buttresses because these are the main supporting structure of the face, and the most important are the vertical buttresses because they define the vertical height of the face and provide the bony support which is required for the mastication. So basically there are 4 types of vertical buttress. The most important are, number 1 is the maxillo-nasal, the maxillozygomatic, the maxillopterygoid, and another important one is the ramus of the mandible. But if you look at the horizontal, they are also equally important because they define the anterior posterior as well as the horizontal dimension of the face, where you have basically the 5 horizontal buttresses. The first one being the frontal bar, which is in the line of the superior orbital rim. The second, the inferior orbital rim. You have the alveolar maxilla, you have the mandibular maxilla, and the lower maxilla. So these buttresses are very important, and any fracture repair that we do, the 4 vertical and the 5 horizontal, we should realign them before we do the repair. And a little bit about nerve, I'll not go much into details, but the most important part is the ciliary ganglion, which lies between the optic nerve and the lateral rectus. So whenever we do any operation within the apex, we should be very careful not to injure the ciliary ganglion. And the blood supply, the most important thing all of you should understand, we all know the ophthalmic artery is a branch of the internal carotid artery. So as it comes from the cranial to the orbital region, you see the ophthalmic artery moves from the medial to the lateral part. So in the orbit, most of the part, the ophthalmic artery lies laterally, even including its branches. But only one thing you see, the central retinal artery, which lies basically in the medial part of the orbit. So the important branches of the internal carotid artery that we see here, the supratrochlear, the supraorbital, the lacrimal, the superior palpebral, inferior palpebral, the dorsonasal, and equally we also have the branches of the external carotid, basically the facial, which supplies the different muscles of the face. So one should have a very clear understanding why I'm telling, because sometimes we need to augment. When we have an inophthalmos following a fracture repair, we see that sometimes we need to augment either with filler injection, the dermal filler, or with a fat. So you should be very careful in the junction between the internal and external so that you don't end up giving any blindness. So let me go to the classification. The pure ophthalmological classification for us is very simple. It is a blow-in fracture or a blow-out fracture. So when a fracture fragment is displaced into the orbit, we call it a blow-in fracture. And this is classically seen in the fracture of the roof, where you can see this is the fracture segment which is being displaced inside the orbit. But what is a blowout fracture? When the fracture segment is displaced away from the orbit, which we see in the inferior wall fracture, and this is classically known as a blowout fracture. The second common classification for us is the pure and the impure. Pure means when you have an intact bony margin, but you can have a fracture in the wall. You can see this is a very classical picture where you have an intact bony margin. So this is a pure orbital fracture. The impure means once when you have a fracture involving the rim and the wall. So this is known as an impure fracture. So for the ophthalmologists, we need to define as either a pure or impure or a blow-in or blow-out fracture. But many of times these fractures are associated with fractures of the facial skeleton, which can be a tripod fracture, which is basically a ZMC, that is a zygomatico-maxillary complex fracture, which can be in the form of tripod or quadrupod. Then the fractures of the Leaford too, like these are the pyramidal fracture which starts from the maxilla, involves the ethmoid, lacrimal and the nasal bone, usually bilateral. And the Leaford tree, it starts from the lateral wall of the orbit, involves the floor of the orbit, the medial wall of the orbit and to the nose. So these are some of the associated facial fracture which we'll see along with the orbital fracture and the NOE fracture, which are very complex fracture that I will come to you later on. When you have an apical fracture, one should be very careful. Why? Because in the apex, we have two important structures, that is the superior orbital fissure and the optic canal. And through this optic canal passes the ophthalmic artery and the optic nerve. And through the superior orbital fissure, we have the most important blood vessels and the nerve, third, fourth, sixth going. So one should be very careful when you operate or do some surgical procedure in the orbital apex. Like this is a patient you can see. There's a trauma in the apex, and this bony fragment is impinging the optic canal, the optic nerve. So this is something very serious where you need to operate, you need to remove this bony segment which is impinging the optic nerve. So next, let us go to another classification, which is a topographical classification. So here comes the ZMC fracture, which I have already mentioned, but you see there's a very important structure here, that is a Wittnall's tubercle, where you get the attachment of the lateral canthal tendon, and any distortion out here, any breakage or any fracture or involving the Wittnall's tubercle leads to a lateral canthal dystropia. Then the next orbital roof fracture, which I had already mentioned, you have the lacrimal fossa here, the trochlear fossa. You should be very careful of the structures. Then the floor, you have the inferior orbital fissure along with the infraorbital groove and also the canal. The medial wall, we have very important structures in the medial one being the anterior lacrimal crest, the second being the posterior lacrimal crest, the third you see here, this is the anterior ethmoidal foramen, the fourth is a posterior ethmoidal foramen, and next is the optic canal. So all this maintains a very important relation, like the distance from the anterior lacrimal crest to the anterior ethmoidal foramen is 24 millimeter. Distance from the anterior ethmoidal to the posterior ethmoidal is 12 millimeter, and the distance from the posterior ethmoidal to the optic canal is 6. So this rule of 24 is to 12 is to 6 should every resident and every fellow should remember it, because whenever you do any surgery, whether a thyroid decompression or a fracture repair medially, you need to see that all these vessels are being maintained and not being injured. The next important is the apex, where already I have mentioned you have the optic canal and also the superior orbital fissure. So when I was talking about the ZMC fracture, I already mentioned it can be in the form of tripod or it can be form of a quadrupod. So when you have the involvement of the zygomatic bone, involvement of the maxilla and the inferior orbital rim, we call it a tripod fracture. But then when it involves the frontozygomatic suture, it also affects some part of the frontal bone, then it becomes a quadrupod fracture. But this fracture is very important, is something very serious, because along with all the cosmetic aberration, which I already mentioned, because you have the Wittnall's tubercle here. So any injury to the Whitnall's tubercle will lead to dystrophy of the lateral canthal tendon. So this cosmetic aberration along with dystropia, but what dangerous thing can happen? This is a trismus. This is because a fracture might impinge upon the coronal process of the mandible. So trismus is very common with a CMC fracture. So what we are supposed to do first, as I have already mentioned, the vertical buttresses needs to be taken care of before we go for the repair of the fracture. When we talk about the orbital roof fracture, these are usually occurs in the children due to the lack of pneumatization of the frontal sinus. They can present with something very serious complication like the intracranial injuries, the CSF leak, the ecchymosis. The ecchymosis is very common because the frontal sinus is very, very vascular. There can be pneumoencephalocele, proptosis, pulsatile proptocystosis, diplopia, and sometimes I have seen the globe being totally subluxated into the cranial cavity. So these are some of the complications of the orbital roof, and the flow is what commonly referred as a blow-up fracture, which is very common for us. We ophthalmologists, we see it very common. Which patient comes with inophthalmos. There's limitation of eye movement. There will be loss of sensation, vertical diplopia, but this is something very serious. It might come with the ocular cardiac reflex, especially when you have a white-eye fracture or when you have a trapdoor fracture. So this really becomes an emergency. So now what we know the ophthalmological classification, that is blow in, blow out, pure, impure. We know the topographical classification, which I have seen. Now, how do the radiologists classify? So broadly, they classify number one as a classical blow-out fracture, which involves both the medial half of the orbital wall, medial to the infraorbital canal. Then the type B is a fracture involving the infraorbital canal, and the type C is the inferior fracture, that is fracture of the inferior along with the medial wall of the orbit. And the type D, they call it the total fracture. What happens? It involves a fracture of both the lateral and medial wall, and then based on the type of the fracture, it is defined as a rectangular fracture, as you can see here. It can be a triangular fracture. It can be a stellate fracture. As you can see, the fracture is in the form of a stellate. It can be in the form of a Y, and it can be form of an I. This eye fracture, which is commonly called the green stick fracture, these are very dangerous because if it leads to entrapment of the muscle will either lead to ocular cardiac reflex or it will lead to a necrosis of the muscle. So this is a white eye fracture. The eye is otherwise not much congestion. It appears white. What you see here, the child moves up, but this eye is not going because there's entrapment of the inferior rectus muscle. So these are highly emergency cases. You need to operate them early. There's chance of ocular cardiac reflex and also chance of necrosis of the entrap muscle. Trapdoor fractures are very important that we encounter because these are very small linear fractures. What happens when there's a fracture? The inferior rectus, it goes down. It falls into the maxillary sinus. But after some times, what happens? The trauma forces ceases, and this bony floor segment, it recoils back. So the bone comes back to the normal position, but not the muscle. This muscle remains entrapped, and this muscle leads to the ocular cardiac reflex. The patient might have bradycardia and other systemic problems. You need to operate them early. As I have already mentioned you, the NOE, that is the naso-orbito-ethmoidal fractures. These are very complex fracture because this involves the whole of the medial part of the orbits. It involves all the 6 bones, that is the maxilla, nasal, frontal, ethmoid, sphenoid, and lacrimal bone. Here the superior boundary is in the cribriform plate. The inferior, you can see, involving up, going medially up to the sphenoid sinuses and also involving the nose. So these are real dangerous fractures and very nicely classified by Markowitz into the 3 types. The type 1 is when you have a single large fracture. You can see there's a single large fracture involving the medial component of the orbit, but the MCT, the medial canthal tendon, is being attached. The type 2, that is, here is a comminuted fracture, the multiple fracture, but still the medial canthal tendon is attached, that is type 2. And the type 3, when you have a comminuted fracture with total avulsion of the medial canthal tendon, that is a type 3. So these type of fractures can be unilateral, can be bilateral, and this is a real complex fracture. Most of the fractures are managed very well by the ophthalmologist. I feel we ophthalmologists, like we can manage any fracture in the maxilla, any fracture in the orbit, but when you have a NOE fracture with a CSF leak, we require the help of a neurosurgeon too. So what are the theories? The theories is one, the buckling theory. Everyone knows what happens when there is an impact on the orbital rim. this floor undergoes some horizontal and rotational deformation. So it will lead to the fracture at the weakest point, and the impact is maximum when this impact comes in the angle of 30 degree. So anything which hits the orbital margin at the angle of 30 degree, this leads to maximum effect, which leads to the fracture in the weakest point. And other is a hydraulic theory. Hydraulic means when there's a blow to the orbit, immediately there's a backward displacement of the eyeball. This increases the intraorbital pressure, and as such, this will also lead to a fracture in the weakest point. So these two are basically the common theories regarding the fracture. So once a fracture patient comes to us, how do you approach? The most important thing is history and the time of occurrence, because this will always help us decide that when do we need to operate and also why we need to operate. The other important things, you should take a history of what has led to this fracture, then any systemic, and this is very important, the photography, because this is not only for the surgical planning or to see your results pre and post, but also for the medical legal purpose. So once a patient comes to us, we need to see the vitals, the A, B, C. We need to see the vitals. Then if we find that he's safe, we do a local examination, examination of a soft tissue, examination of bone. The best way is to see the bone is imaging, and you see whether the patient has got some serious signs and symptoms in the form of retrobulbar hemorrhage, emphysema, optic nerve trauma, or has signs of oculocardiac reflex. Then these are the patients which requires immediate treatment, or otherwise we just observe and see whether at how early we can do the surgery for him. And the clinical features are basically, there's a very long list of clinical features. I think most of the residents and the fellows must be knowing, but the most important thing is aspect that you need to check the vision, you need to check the intraocular pressure, you need to know the status of the optic nerve by seeing the pupillary reaction. And you need to check the other parts, both the anterior and the posterior segment, and then you go for a thorough evaluation of the orbit, because many a times we find the impure fracture. We find that the orbital rim is deficient. So this will help you plan the surgery if you do a very good evaluation of the orbit. And Hertel's exophthalmometry is very important, because we know that one of the indications for fracture repair is inophthalmos. So if there is difference between the two eyes of 2 millimeter, then you need to do an early surgery. So how do we image? We all understand that CT is a gold standard for the for the imaging. And when you do a CT, you need to see in the axial, you need to see in the coronal, you need to see in the sagittal section. So here what you do, this is what you can see. I'm putting the cursor here and also the cursor here, where I want to see both the axial and the coronal. And this cursor, when it falls in the axial plane, it should be exactly in the same plane in the coronal and the sagittal. Like here, you see, this is my cursor here, and this is a fracture here, which is very posterior. Exactly, the coronal is also showing the same fracture here in the posterior part. Here you don't even see the globe, somewhere near the apex of the orbit, and here also in the sagittal you can see the cursor showing that it is much posteriorly. So all the three views are very important in order to decide that what type of repair that you are planning for the fracture. And this is what we do. We need to use the software to see. Simultaneously, we need to see whether both the axial and the coronals are corresponding to each. You need to use different bone windows in hot colors, cool colors, or you need to use a grayscale to know the bone windows, so that you can remove the soft tissue. You know the expansion, what is the maximum expansion of the socket, which will help you to give the maximum amount of volume. And the most important is this 3D evaluation, because this will help you to assess how much is the inophthalmos. See this child here, this is so full, and this is the fracture cell. Here you can see that this is the inophthalmic, hardly any sulcus that you're seeing here. So evaluation is very important. So as I have mentioned, CT is a gold standard, provided if you do not have a metallic foreign body. But along with the CT, when you have an apical fracture, when there is an apical injury, you need to do a MRA. Because in my personal experience, I have seen many patients having acute CCF when they have a fracture of the orbit. So this is our optic canal. So you need to do a MRA, you need to know what is happening in the circle of Willis, you need to know what is happening in the cavernous sinus, and also you need to know the arrangement of the blood vessels. I'm just stopping here. If you look very carefully, see, this is my ophthalmic artery. And this is, you can see how the ophthalmic artery is trying to go from the medial to the lateral side of the orbit. So every structure should be well visualized, should be well understood and read before you take up for the surgery. And this is also when you do a surgical planning. Like this is a patient who comes to me with a fracture. Can you see he has a NOE fracture, the roof fracture, the inferior wall floor fracture, and also the lateral fracture. So he has got fracture every part. So here you really need to do a very good surgical planning, and the best way is to do a 3D print. I do many cases, I do a 3D print. Prior to the operation, I plan what implant I need to give, how much amount of volume I'm supposed to give. But somehow in India, we do not have the 3D customized implant which comes to you in a sterile form. So if that would have been available, then we could have done a much better reconstruction. But 3D planning is very important before you take up all this type of complex fracture. Now the question comes to us, when to intervene? Immediate when there's intractable diplopia in the primary gaze, when there's an oculocardiac reflex, especially in white-eye fracture or the trapdoor fracture, when there's very early gross enophthalmos, and when there's a globe subluxation. We need to wait sometimes approximately 2 weeks when we see that, okay, there is symptomatic diplopia with a positive force reduction test, with a large floor, with a progressive infraorbital hypostasia. However, if the diplopia is very minimum, there's good ocular motility with no significant enophthalmos, I don't think that those are the cases you really need to operate. You just need to observe those patients. So here I'm showing a very simple way how we do a fracture repair. This is very simple technique of doing a fracture repair. You can see the most important thing, you have to do a canthotomy and cantholysis in order to give space to this orbit. You need space to manipulate within the orbit. Then you incise your periosteum, and this is the fracture. You can see the fracture along with the entrap muscle. So by a very careful hand over hand technique, very carefully you try to pull. Supposing if this entrap muscle is not coming out, you can also use a raunchure or something to make the fracture site bigger, so that all of the structures you can bring it back to the orbit, and then depending upon the size you can put the implant. There are different types of implant. People used to use silicone or the porous implant, but I usually prefer the titanium implant because they're very biocompatible and they have a self-drilling screw. So very nicely you can fix the screw, you can give the implant, and also for a very, very long follow-up period also you will not see that any like extrusion or anything. Like these titanium implants are real good implants. So this is what you can see. This is a very simple way. Then you can close the periosteum, and sometimes I close the conjunctiva. But it is not mandatory that you have to close the conjunctiva, but even if you don't close, you have to be very sure that they are aligned in proper position, so that in order to prevent the post-operative symblepharon. So I usually give 3 sutures in the conjunctiva in order to prevent the post-operative symblepharon. Like this is a patient of a white-eye fracture that you can see here. When the patient looks up, the left eye fracture side, it does not go up. When the patient looks down, it doesn't go down. So following the surgery, you can see the eye goes up very well, and also it goes up very well. This is another patient. This is a fracture that you can see, a very big fracture. And then this is post-operative. You can see very adequate correction, both cosmetically and also the good ocular motility. This is a girl, she is very sad. Like you can see, the eye has been totally enophthalmos, totally depressed, and you got a very good correction following the surgery. So this is another girl where you can see a big fracture, but the question is that how do we give them very appropriate volume? The best way, if we do a mirroring, let me stop here and show you. The blue is over here. The blue over here is a normal orbit, and the pink is the fractured orbit. So you need to, this is my fractured orbit. So you need to superimpose the normal over the fracture so that you can measure the distance and you can measure the actual amount of volume that you want to reconstruct. So this is my normal orbit. This yellow is my fractured orbit. So this is a mirroring that I have done. So now if I measure this distance, I need to measure the distance from here, and then I will know exactly in millimeter how much amount of volume I need to give to the patient. And this is how we do a mirroring. See, this is my fractured side. This is where the fracture has gone. And now this normal, this is with the navigation system that I'm showing you. And now I have mirrored the normal over the abnormal. And this is a deficiency. You can see almost 9 millimeter deficiency he is having on in both the medial and also the inferior wall. And then when you put the probe before the operation, you can see this is a navigation probe going deep down into the maxilla. And then once you do the repair, so I know now that I need to give at least around 6 to 9 millimeter of the volume. So this is a titanium implant which I have customized. I have molded it, and I have molded it approximately around 6 to 7 millimeter. Placed it in the fracture site, and after placing, you need to recheck that whether you have done the appropriate amount of correction or not. And this is once you place the screw, you place the implant, and this is being done. And then again you use the navigation. Now you see my navigation probe does not go down because I have already placed the implant very nicely. My navigation probe is showing that yes, I am in the correct plane, and whatever amount of volume I wanted, you can see here very well, whatever amount of volume I wanted, I have corrected it. And this is the result you get. So this is really beautiful result. If you really want to give volume, if you really want to do a good cosmetic correction, then this is what we usually do. We do a mirroring and we give the adequate volume. Sometimes the patient comes to us with a very bad fracture and they come to us very late stage. Right? This is a patient who comes to me with a very total globe dystopia. He had no inferior orbital wall and he had no anterior part of the maxilla. So when I have opened him, you can see this is the inferior part of the maxillary sinus, and these are the only two parts of the inferior orbital wall. So now how do I reconstruct the inferior orbital wall? I cannot use anything solid because it might lead to compartmental syndrome. So what I have used a titanium mesh, which is used normally by the neurosurgeons. So I have measured it. So this forms my inferior orbital wall, and I have screwed it on the other side. So this is forming the inferior orbital wall, and we have a hole, so there cannot be any compartment syndrome. And now I need to reconstruct the anterior part of the maxilla, which has been done with a biopore implant. I have glued in on either side. So now I have reconstructed the orbit, but how do I give the soft tissue to this patient? And to give a soft tissue, I need to have some vascularized tissue over this implant. So what I have done, I have stitched the subvenous tissue above this implant, and then I have used a full thickness skin, dermis, and a fat graft to give him also some of the soft tissue volume. And this is the same patient day one following the surgery. You can see this is the skin and dermis given in as one graft. And this is when the patient came to us with a 30 days follow-up. And this is how good he looks in the lateral view. And this also patient, we had done the mirroring. And this is final approximately a year post-op. At least you can say good amount of volume has been given, a good amount of correction along with the correction of the dystopia has been done. This is also another very interesting case. If you look very carefully, the patient does not have an inferior and or a medial wall, so lateral wall. So what we have done again this 3D printing. So if you look carefully, then you can also plan there. Where do you want? See, he doesn't have a lateral wall. So where do you want to place the implant? Do you need to give a volume on the lateral side? We did not find much difference laterally. So the only concept was to give some volume inferiorly. And that is what the volume has been given, as you can see here. And this is the incision transconjunctival. So we get the two implants. This is from the striker. This is from the synchrony, where you can see you have the bigger size. So that is the compartment syndrome, and you get a very adequate correction. So I was mentioning to you as a NOA. So this NOA picture, that is the naso-orbital ethmoidal fracture. If this patient comes to us late, when you are sure that there is no CSF, it can be very well managed by an ophthalmologist. So when you look to this patient had total fracture of the inferior orbital rim, as you can see here. The total fracture of the medial wall involving the ethmoid, the nasal, and also the lacrimal bone. So this is a patient which we need to operate because we know there is no CSF and it's a delayed case. He has got gross in ophthalmos. So the first thing, how do we give a volume? So we have done also a 3D printing of this patient, and now what we have done, we have used this MTM. This is the MTM implant. This is Medpore, titanium Medpore. So the first layer of the Medpore is giving me a volume of 1.5. The second layer is giving me another 1.5, and the third is giving me, and the titanium is giving a 1.5, 1 to 1.5. So with this implant in one go, you can give a volume of approximately 5 millimeter. So this is something very wonderful, and I have molded it so that in the same sitting, I can correct both the medial wall fracture. Basically, this is to give the volume, to correct the inophthalmos and the canthal dystopia that he has been having, to correct the canthal dystopia. So this is what you can see. This is the impure fracture, as you can see here. And this, the fracture, what we have done, we need to form the buttress, but there was no bone out here. So what we have done, this implant, which also helps in reformation or redesigning of the buttresses that I have already mentioned here, that is the buttress number 2, the inferior orbital rim, then also giving the volume. And the third most important thing, you need to fix the implant so that it will not migrate later on. So these screws are very easy to drill because it is self-drilling, and these are all the screws that you can see here. And then once you have given volume, you have corrected the fracture. Basically, to give the volume, because a late fracture, you need to correct the dystopic MCT, medial canthal tendon. So what I have done, I have used the 3O Prolene suture, and I have taken the bite through the periosteum in order to correct this MCT, dystopic MCT. And this is one of a very recently done surgery, and you can see the post-operative very adequate correction. We could give him a very good volume, like he might require more surgery later, but this is done very recently. You can see we could give him a very good adequate amount of volume, and also the dystopia has been corrected. This is another interesting case I want to show you. Can you see he came to us like this, the total globe dystopia, this total MCT medial canthal dystopia, and also there has been so much of inophthalmos. So when we have done a 3D, when we have done a CT scan, most of the bone fragments are within the maxilla, and you can see the whole of the medial wall, the whole of the inferior wall has been totally fractured. So we have taken him up for surgery. This important step is lateral ganthotomy, then the cantholisis, then you make the incision. Here my main aim is to correct both the dystopic medial canthal tendon along also to give him volume. So when we have decided to give him volume, I felt that the MTM is quite expensive. So what we have done, we have used a biopore sheet, and we have given the biopore sheet in 2 layers in order to give him adequate volume. So a transconjunctival incision is done, as you can see here. And once you do a transconjunctival, you expose the fracture site, and you can see this still most of the orbital tissue is still within the maxilla. So you need to release, and there's an old fracture. So slowly you release. You measure the size of the implant. We usually measure what is the vertical and the horizontal depth size of the diameter of the implant. And then the implant that we have used for him is basically a biopore implant, and this biopore implant in 2 layers. So you can see these are 2 biopore implants together, which we have stitched with a Prolene suture. We have molded it. We have placed it in order to give volume. So these are little late cases. So you can give volume to such patients, and along with it, now on the table you are sure there is inophthalmos has been created. Now how do you, this MCT, the medial canthal tendon is totally fibrosed. Now how do you reconstruct the medial canthal tendon? So what we have done, we have taken the T-shaped titanium plate. So now you'll be seeing in the next, you can see this is the T-shaped titanium plate that we have designed, and we have done a very good dissection and could find both the posterior and the anterior limb of the MCT. So the posterior limb has been sutured to the vertical limb of this T-shaped titanium implant, and the anterior limb has been sutured to the horizontal, the mid opening, the horizontal limb. So you need to re-suture this implant, the MCT, and then it can be screwed off. Then you can put the screw. So this is the anterior part of the MCT, and this is being sutured to the horizontal limb. And this is also being done recently because we had to defer this patient because of COVID, and now since we are almost near normal, so these are the cases again coming back to us for the repair. And then you fix it with a screw, and then once it is being done, and you can see, you can close it, the subcutaneous tissue in 2 layers. Number 1, the subcutaneous tissue, and number 2, the skin. This is like you can see the screw has been played through the lateral 2 opening of the titanium plate, and once the surgery is done, you can see the buttresses have been taken care of. These are the plates. So these are basically you take care of the buttress, and also we have also given volume. This is not coming very well, the volume, because we should have taken a more posterior scan, but at least the initial buttress that has been corrected with the titanium that is being seen, and this is on the table. This is on the table. You can see at least a good amount of volume, and the medial canthal dystopia has also been corrected. But sometimes you get endo fracture like this. So these are the situations where you really need the help of the neurosurgeon, why I'm saying, because they have the fracture of the cribriform plate, and this leads to lots of CSF leak. So when this patient came to me, I was wondering, oh my God, what to do for this patient. Immediately, I covered both the cornea with some good amount of ointment. Went to the neurosurgical unit along with a neurosurgeon. We have done the surgery, and you can see there has been fracture. This is a very classical NOA fracture that you can see here. The whole bone, the cribriform plate, the ethmoid, which is a cribriform being a part of the ethmoid, everything is been broken. And then this has been first taken up by the neurosurgeon, where they have made the burr holes on the skull, removed the skull, and they have managed the part of the dura mater that was being ruptured, and also they have put the special dura sheets and the dura seal, and the next part was taken care by us, basically to replace the globe, taking care of the buttresses. This is the fracture which we have placed in the NO region to give some volume to it, and also we have also given a plate on the lateral part. We need to redefine the position of the lateral buttresses, and then this is at the end of the surgery, and this is a zygomaticomexillary suture that has been redefined with the buttresses. So, and this is how the patient looks. At least we could push back the globe, and this is how he was before the accident. And seeing this, it is extremely sorry picture for all of us, and this is after the surgery. Now let me come to the orbital apex and the optic canal fracture. When we talk about the optic canal fracture, these are very challenging because many times they come with a traumatic optic neuropathy, and this traumatic optic neuropathy may have a fracture. Like you can see, this is a lateral wall fracture. This is my canal out here, optic canal, and this is a fracture here. Along with, there is a fracture of the lateral wall of the sphenoid sinus. And this is a classical traumatic optic neuropathy, the direct type. But look at here. The two optic canals are very clear, but what we see here, we see the hemorrhage within the sphenoid. So in spite of having a very clear optic canal, this has an indirect traumatic optic neuropathy. This is because by compression by the sphenoid sinuses. And then when you evaluate that, I have already mentioned the same cursor. See, you can see this cursor which is showing the median wall of the optic canal being fractured. Here you can see that exactly in the coronal and also in the sagittal you can see. And this is how we read. A fracture. The cursor should come from below to above, and you can see how as it is coming down. See, this is my supraorbital fissure. This is my optic canal. Exactly same is coming out here and same is coming out here. And when you see a fracture here, the fracture is here. Let me stop here. Let me come here. Yeah, this is my fracture. The same thing you're also seeing in the sagittal. The same thing you're also seeing this fracture in the coronal. So in all the plane, whether it's an axial, whether it's a coronal, whether it's a sagittal, it's very important that you need to follow all the plane. Then you need to plan up for the surgery. So the most common problem with the apex fracture is a traumatic optic neuropathy. But interestingly, till today, there are no clear guidelines available in the literature for the optimum management of traumatic optic neuropathy. And most institutes, most centers are managing with customized or the tailored approach. Basically, we know that there are two ways of treating. One is a mega dose of steroid, and other is the surgical decompression. But very interestingly, there were 2 decades back, the International Optic Nerve Trauma Study, they have done a multicentric study, and following the study, they concluded that neither steroid nor optic canal surgery should be considered the standard of care for patients with traumatic optic neuropathy. So this has led to a very big controversy that whether we need to observe this patient, whether we just end up we treat them only with steroids, or whether in spite of saying that there is a bony segment impinging upon the optic nerve, whether we should go ahead with the surgery. Then a few years later came the NASIS study. They say that in such patient, instead of doing a surgery, if you give a very high bolus dose of steroid, then chances of visual recovery or chances of spinal recovery is high. But again, crash study comes down, and they say that if you give very high dose of steroid, there is high risk of death. So again, the controversy. Till today, we don't know that what we are supposed to do with such patient. So what I follow, so what the consensus guideline says, that we can tell the patient, we can tell them that we'll do nothing and hope that the vision will improve someday. Or we can also tell them that let us try doing something, let us do a surgery, and also the hope and the vision will improve. And when I talk of surgery, This surgery can be done by endoscopic approach or by the transcranial approach. Endoscopy is preferred and is done very beautifully by many surgeons. I know as a surgeon, ENT surgeon from PGI, doing beautiful endoscopic surgery for the traumatic optic neuropathy. But only fear is that the chance of CSF leak is higher when you go by endoscopic approach, number one. Number two, meningitis may be higher because you open the optic nerve with the canal to the nose, because we go to the nose and nose has got maximum is the most important source of infection. So it just opens up the pathway. And when we talk about neurosurgical, this becomes a more major surgery because it goes a bicoronal approach, and the neurosurgeon basically ends up decompressing the superior wall of the orbit. So what as ophthalmologists, what we can do? So we have started a very novel approach. We thought that being an ophthalmologist, let us go by an orbital approach and try to decompress the optic canal. So the question asked that I'm sure many of the residents or the fellows will be asking me, why orbital approach? Now, if you look this picture out here, so if you look to the picture here or look to this imaging, you see this is my ophthalmic artery, which is a branch of the internal carotid artery. So as it moves from the cranial to the orbital part, the ophthalmic artery moves from medial to the lateral. So the major part of the ophthalmic artery, especially in the orbit, is in the lateral part of the orbit. And exactly you can see here, like in the cranial part, it is medial to the orbit. And as it comes towards the orbit, this ophthalmic artery, this is the lateral side, this is the medial side, this is the optic nerve. So this ophthalmic artery, it lies lateral to in the orbit as we come to from the cranial to the orbital part. And the second question, why orbital? If you look to the optic canal, it is basically an hourglass shape. So the average diameter of the optic canal in the cranial part is approximately 7 to 8 millimeters. So you can see it is horizontally well dilated, and in the orbital part it is only 4.8. So it is very difficult to reach the anterior part of the orbit by either endoscopic approach or even by transcranial approach. So this is part, if I have seen that you just need to decompress this toughest part, this is the orbital part, then this opens the sphenoid sinus, the whole of the canal gets decompressed. And the second thing, like if you look to this skull out here, if you look to this skull, so this is my skull, which is showing this is my optic canal, and other is the supraorbital fissure. So if you decompress this superior medial part of the optic canal, so you can see in the this is my optic canal, this is my sphenoid sinus. So it opens up the sphenoid sinus, and we all know the sphenoid sinus forms a medial wall of the optic canal. And if you use a navigation, then what happens, we can assess the length of the optic canal before the surgery, because we all know the optic canal length varies from 0.6 to 1 centimeter, 1.1 centimeters. So also you know the arrangement of the sinuses. Sometimes we have type 3 optic nerve where the optic nerve itself is within the sphenoid sinus. So if you can image it well before the surgery, and if you can color code it, it becomes a much safer surgery for the patient. And this navigation probe intraoperatively will tell you whether you are in a proximal or distant part of the canal, or whether you have reached the targeted area. So let me show you a very small surgery. So this is a fracture which is impinging the optic nerve within the optic canal. So this is my coronal and this is my sagittal view. So here I do a very, very minimally invasive surgery, and this is under navigation. So after the registration, so only incision is approximately a 4 millimeter incision transcarincular, and then you get, this is my anterior ethmoidal blood vessel. You cauterize it, go further deeper, then you get the posterior ethmoidal blood vessel. Here we do not cauterize. Why we do not cauterize? Because it is 6 millimeter. I think you remember my anatomy, the 24:12:6. So 6 millimeter beyond lies the optic canal. So as you keep on going down, this is the optic canal that you can see, and this is the annulus of the zinc. So when you see this annulus of the zinc and you see this optic canal, you just need to decompress the toughest, the hardest part of the optic canal, and then the whole of the optic nerve is seen very well. And then when you put the navigation and it shows that you have reached the targeted area, that means you are done with the surgery. So I'm just sharing some of my patient, like you can see this is so well documented, a small fracture segment impinging the optic nerve out here. And then this is the VP before operation. This is after a month, the same patient, as you can see here, beautiful VP, and also after a year, the VP still stands very good. And this is what interesting. We do a OCT RNFL, and when you see the RNFL, see this is totally atrophied out here. But see the post-operative, this atrophy is much reduced following the decompression in the same patient that I have shown you earlier. And this is another patient. This is also direct traumatic optic neuropathy, but what is here, you see, this is by a hematoma. And this hematoma is within the canal, and this is impinging on the optic nerve. So these are the situation where we have tried 3 doses of steroid, and the patient still has got very poor vision. You need to correct, you need to decompress. So same, the navigation surgery has been done. You do a good registration. After doing a good registration, it's a very minimally invasive. See, you get the anterior ethmoidal blood vessel, you cauterize it, go further posterior, you get a posterior ethmoidal blood vessel, but do not cauterize the posterior ethmoidal because it is very near to the optic canal. Then once you go further down, you see this is the posterior ethmoidal blood vessel. So you need to go further down, and then you reach the optic canal. You see the annulus of the zinc. You remove the tough anterior and the superior part of the optic canal through the orbital approach, and this will open up the optic nerve. So the optic nerve you will see as a white sheet, but this is the case of indirect traumatic, this is a case of hematoma leading to a traumatic optic neuropathy. So you need to remove the hematoma. See, now it is so my navigation is saying that this is what my navigation shows, whereas my target is much below. So I need to reach much further. This is my trajectory mode, which is showing that, okay, I need to go further deep inside the orbit in order to decompress whole of the canal. And this is the final bone segment that has been removed, and this is a surgery I do under the microscope because it's not possible to do with the lip. And this is the optic nerve here that you can see, and this is the annulus of the zinc. So being a hematoma case, so I had made some small puncture in order to remove the hematoma. So with MVR, you can make a puncture on the optic nerve sheet, and this will drain up the blood. And this is and for the closure, it's very simple. You can just give 1 or 2 sutures in the caruncle that where you have given the incision. And this is the VP. See the VP, and see the VP. This is after few days, and the technician and the consultant for the VP has written very nicely that it has a normal latency, and but though it's a reduced amplitude. But before operation, it was totally extinguished. So there were not any curve, but at least you could see some curve. And there has been gross improvement of vision in this patient. Why? Because it was not by a bone. And when I have done the ganglion cell analysis, this is something very interesting we found. See, the pre-operative and post-operative, there is an improvement in this analysis because it was by a hematoma. This under the patient, you can see the fracture in the optic canal. Then this is a VAP before. Post-operative, many patients we see the latency improve. That this is sign that means the exoplasmic flow must have improved, or the blood supply has improved. And this is the OCT RNFL where you can see there is hardly any atrophy you see. There's except for 1 clockers, you hardly see any atrophy. There's also improvement in the GCL. This is very controversial. Even I find something very interesting, seeing an improvement of the GCL. As you can see in this patient, we have reported our technique as the first case to do a navigation-guided orbital optic canal decompression for traumatic optic neuropathy. But before I close, before I end up my lecture, I'd like to mention that to do a very safe and a precise surgery, image guidance, that is navigation, usually helps the surgeon. And also we can follow the basic principles of get it right the first time. So because this type of orbital apex fracture is not possible to keep on operating, so the first go we have to take all precaution, we have to do very nice evaluation, and also we need to take up this challenge. I have done approximately 62 to 64 surgery, and at least in my hand I have seen at least 35-40 patients improving some amount of vision. 1-2 patient has really improved very good. I'm not telling that all patients have improved their vision, but at least more than 50% has improved their vision. So I feel that this even the navigation system that we are using for routine operation for traumatic optic neuropathy and for the complex surgery, it is really helping us, especially to localize any lesion within the apex, the blood vessels. And also I feel that it is one of the most useful technological advances for reconstruction of the complex orbital fracture, because we can do mirroring, we can find out the volume, and also for the optic canal decompression. I'd like to acknowledge my team here, Dr. Ganesh, who is a consultant, Dr. Vatsala, Dr. Aditi, and also Dr. Shyam, who is always with me during most of my procedures. Thank you very much for the patient hearing.